So now it is about stroke volume. Stroke volume is the volume of blood pumped out of each ventricle per beat or contraction. As the stroke volume increases, the cardiac output also increases. Stroke volume depends upon end diastolic volume contractility. Stroke volume equals to end diastolic volume minus end systolic volume. When the heart contracts strongly, the end systolic volume can be decreased to as little as 10 to 20 milliliters. Conversely, when large amounts of blood flow into the ventricle during diastole, the ventricular end diastolic volume can become as great as 150 to 180 milliliters in the healthy heart. By both increasing the end diastolic volume and decreasing the end systolic volume, the stroke volume output can be increased to more than double normal. Men on average have higher stroke volumes than women due to the larger size of their hearts. However, stroke volume depends on several factors such as contractility, duration of contraction, preload, that is end diastolic volume, and afterload. Now, what are the components? Stroke volume, amount of blood pumped by each ventricle per beat or per contraction, that is 80 ml, and stroke volume depends on end diastolic volume and contractility. Prolonged aerobic exercise training may also increase stroke volume, which frequently results in a lower heart rate. Reduced heart rate prolongs ventricular diastole, increasing end diastolic volume and ultimately allowing more blood to be ejected. It is cardiovascular conditioning in athletes. Stroke volume is intrinsically controlled by preload, the degree to which the ventricles are stretched prior to contracting. An increase in the volume or speed of venous return will increase preload, and through the Frank-Starling law of the heart will increase stroke volume. Elevated afterload, commonly measured as the aortic pressure during systole, reduces stroke volume, though not usually affecting stroke volume in healthy individuals. Increased afterload will hinder the ventricles in ejecting blood, causing reduced stroke volume. The resistance to the ejection of blood by the ventricle is called afterload. The left ventricle, for example, must create sufficient pressure during systole to overcome diastolic arterial pressure and systemic vascular resistance before any blood is ejected. While preload enhances contractility and stroke volume, high pressures in the arterial vessel during ventricular end diastole is inversely related to stroke volume. While systemic vascular resistance is not easily determined without a pulmonary artery catheter, diastolic blood pressure is easily measured. So while an accurate estimate of afterload is often not clinically practical, a patient's diastolic pressure provides a good indication of the resistance the left ventricles must overcome. In general, the higher the diastolic pressure, the higher the afterload. Afterload is also tied to cardiac hypertrophy. As the resistance to chamber contraction increases, the chamber adapts to this increased workload with the accumulation of increased fiber within the myocardial cells. This makes the cells stronger but also bulks up the cells, ultimately resulting in chamber hypertrophy. Unfortunately, these thicker chamber walls can be associated with additional complications such as decreased contractility, reduced stroke volume, and cardiac dysrhythmias. The stroke volumes for each ventricle are generally equal, both being approximately 70 ml in a healthy 70 kg man. Men on average have higher stroke volume than women due to the larger size of their hearts. Now, regulation of stroke volume, regulated by three variables: end diastolic volume, volume of blood in the ventricles at the end of diastole, sometimes called preload. Stroke volume increases with increased end diastolic volume. Total peripheral resistance, frictional resistance in the arteries, inversely related to stroke volume, called afterload. Contractility, that is strength of ventricular contraction. Stroke volume increases with contractility. Ejection fraction, percentage of the end diastolic volume that is ejected per cardiac cycle. Stroke volume equals to end diastolic volume minus end systolic volume, and ejection fraction is systolic volume by end diastolic volume into 100. Normal ejection fraction is about 50 to 65%. Relationship of cardiac output and venous return. Venous return, it is the quantity of blood returned from all over the body through the veins into the right atrium each minute. Venous return equals to cardiac output. And cardiac output and venous return curve, it is easy and simple. That is, cardiac output liter per minute is plotted in the vertical axis, and right atrial pressure millimeter of mercury, it is plotted in the horizontal axis. And we can see the cardiac output curve and venous return curve and their meeting point, that is 5 liter per minute, and it is the same curve. And now here, when the increased blood volume is there, there is increased venous return. So venous return is increased and it is seen in the dotted curve. How total peripheral resistance affects cardiac output. And here in the curve we can see, that is, if there is total peripheral resistance is increased, then the both curves are lowered down, that is the venous return and cardiac output, and their meeting point is also lowered. In the dotted curve we can see when the total peripheral resistance are increased. And it is plotted against in a different curve. What is venous return? End diastolic volume is controlled by factors that affect venous return. Total blood volume, venous pressure, driving force for blood return. Venous have a high compliance, stretch more at a given pressure than arteries. Veins have thinner walls. Veins are capacitance vessels. 2 to 3 of the total blood volume is in veins. They hold more blood than arteries but maintain lower pressure. Factors in venous return: pressure difference between arteries and veins, that is about 10 millimeter Hg. Pressure difference in venous system: highest pressure in venules versus lowest pressure is vena cava into the right atrium. Sympathetic nerve activity to stimulate smooth muscle contraction and lower compliance. Pressure difference between abdominal and thoracic cavities in respiration and also by blood volume. The physiological variations of cardiac output, that is age, it is more in adults than in children. Gender, more in male than in females. Altitude, that is it is increases at high altitude. Pregnancy, increases during pregnancy. Exercise, increases during exercise. And emotion, it increases during emotional expressions. Pathological variation of cardiac output: pathological increase, hyperthyroidism and fever; pathological decrease in hypothyroidism, hypovolemia, hemorrhage, myocardial infarction. Methods of measuring cardiac output, that is invasive pulmonary artery catheter, that is by dye and thermodilation technique using fixed principle, and in the non-invasive techniques, that is esophageal Doppler, endotracheal cardiac output monitor, transthoracic echocardiography and impedance cardiography. And this is the machine, and how it is placed is shown in this picture. Now what are the advantages? It is minimally invasive, minimal interference from bone, lungs and soft tissue as seen with transthoracic route, quickly inserted and analyzed, little training required, very few complications. And what are disadvantages? May require sedation, user dependent, probe may detect other vessels, as for example intracardiac, intrapulmonary, contraindicated in esophageal surgeries, depends on accurate probe positioning. Measuring cardiac output using fixed principle dilution methods, pulmonary artery thermodilution and Doppler ultrasound method, impedance cardiography. Features of an ideal cardiac output monitor: it is safe and accurate, quick and easy to use both in terms of setup and interpretation of information, operator independent, that is, skill of the operator does not affect the information collected, provide continuous measurement, reliable during various physiological states. Methods of measuring cardiac output. Fick principle, that is gold standard, is cardiac output ml per minute, a VO2 ml per minute divided by arteriovenous difference of O2. Fick principle relies on the total uptake of a substances by peripheral tissue is equal to the product of blood flow to the peripheral tissue and arterial venous concentration difference of the substances. So cardiac output ml per minute, that is VO2 ml per minute divided by arteriovenous oxygen difference, and in the lungs we can see that in right heart O2 is 100 ml per liter, and in the lungs oxygen is used, that is 200 ml per minute, and cardiac output here is 5000 per ml per minute, and O2 in left heart is 200 ml per liter, and using this fixed principle we can measure cardiac output. Mixed venous flush is usually obtained through a catheter inserted into the brachial vein of the forearm, through the subclavian vein down to the right atrium, the right ventricle or pulmonary artery. Systemic arterial blood can then be obtained from any systemic artery in the body. Fick cardiac outputs are infrequently used because difficulties in collecting and analyzing exhaled gas concentration in critically ill patients because may not have normal VO2 value. So, indicator of dilution method. Based on how fast the flowing blood can dilute the substances introduced into the circulation, a known amount of a substance such as a dye is injected into a large systemic vein or preferably into the right atrium. The concentration of the dye is recorded as the dye passes through one of the peripheral arteries, giving a curve. That is Stewart-Hamilton equation. Cardiac output ml per minute, that is milligrams of dye injected into 60 divided by average concentration of dye in each millimeter of blood for the duration of the curve into duration of the curve in seconds. And here we can see the curve. Area under the curve is inversely proportional to the rate of blood flow. And here we can see what happens in the rest and in case of exercise. It is in the vertical axis, that is milligram per liter, and times in the horizontal axis it is plotted. In thermodilution method, in which the indicator used is cold saline, affected by the phase of respiration and should be measured at the same point of respiratory cycle. Variations in the speed of cold water injection can result in altered measurement. It is a popular indicator dilution technique. A cold solution of 5% of normal saline, temperature at 0 degree centigrade, is injected into the right atrium from a proximal catheter port. This solution causes a decrease in blood temperature in right heart and flows to the pulmonary artery, where the temperature is measured by a thermistor placed in the pulmonary artery catheter. And it is the instrument shown in the picture. The thermistor records the change in the blood temperature with time and sends this information to an electronic instrument that records and displays a temperature time curve, that is thermodilution curve. And it is the thermodilution curve, and the area under the curve is the cardiac output by Stewart-Hamilton equation. The degree of change is inversely proportional to cardiac output. Temperature changes is minimal if there is a high blood flow, but temperature change high if blood flow is low. The cardiac output can be derived from the modified Stewart-Hamilton conservation of heart equation. This cardiac output equals to V1 first bracket TB minus T1 K1 into K2 divided by del TB, T and dt, where V1 is injectable volume in ml, TB temperature of pulmonary artery blood, T1 injectable temperature 0 degree centigrade, K1 equal to density factor, K2 computation constant taking in account the catheter, dead space and heat exchange in transit, both computation constant. Denominator change in temperature and change in time corresponds to the area under thermodilation curve. Now, what is the relationship with BP? As cardiac output is made up of heart rate and stroke volume at rest, these are relatively constant. With exercise, the heart beats faster, more blood is pumped out with each beat, contributing to a rise in BP. Changes in the volume of blood within the cardiovascular system is also affects BP. A person was severely dehydrated or lost a large quantity of blood through a wound, there would be less blood for the heart to pump, thereby reducing cardiac output and BP. For a typical fit young person, the cardiac output might go up to about 20 liters per minute at the peak of exercise. For a world-class athlete in an endurance sport, the maximum cardiac output might be around 35 liters per minute. The regulation of cardiac output. It means maintaining a constant cardiac output around 5 liters per minute under normal conditions and adjusting the cardiac output as per the physiological demands. It has to be regulated to have an optimum cardiovascular efficiency. Now, mechanism of regulation. By venous return, force of contraction of a muscle fiber is proportional to its initial length. It is known as Starling's law of muscle contraction. The role of Frank-Starling mechanism. Now, Frank-Starling law, it states that within physiological limits, the heart pumps all the blood that returns to it by the way of veins. Increased venous return, cardiac muscle stretches to greater length, ventricular muscle contracts with greater force, increased cardiac output. It is Frank-Starling law of heart. And by nervous system, autonomic nervous system takes a major role in the regulation of cardiac output. Whenever sympathetic nervous activity increases, is it during emotions, exercise, etc., it will stimulate both SA node as well as ventricular myocardium. This will increase both heart rate as well as force of contraction of muscles or stroke volume. This will return increase cardiac output. In parasympathetic activity increases as during sleep, it will inhibit SA node, it will decrease heart rate, this will return decrease cardiac output. Hormonal regulation of cardiac output. Whenever adrenal level in the blood increases, it will stimulate SA node and ventricular myocardium. This will increase both heart rate and stroke volume. This will in turn increases cardiac output. The limitation for the cardiac output. There are definite limits to the amount of blood the heart can pump, which is expressed quantitatively in the form of cardiac output curves. The plateau level of this normal cardiac output curves is about 13 liters per minute. Hypoeffective, the lowermost curves are for hypoeffective hearts that are pumping at levels below normal hypoeffective heart plateau, that is 5 liters per minute, and hypereffective, the uppermost curves are the hypereffective hearts that are pumping better than normal. Now, what is hypoeffective heart? In this, the heart is pumping at a very slow rate and the cardiac output decreases. Factors that can cause hypoeffectivity are following: increased arterial pressure, inhibition of nervous excitation, abnormal heart rhythm, coronary artery blockage, valvular heart disease, congenital heart disease, myocarditis, cardiac hypoxia, and hypereffective heart. In this, the heart is pumping at a high rate and the cardiac output increases. Two types of factors can make the heart a better pump than normal. One is nervous stimulation. It involves sympathetic stimulation and parasympathetic inhibition. Hypertrophy of the heart muscles. It involves the increased mass and contractile strength due to exercise and causing hypertrophy, which allows increased cardiac output. Pathologically high or low cardiac output. In healthy humans, the average cardiac outputs are surprisingly constant for one person to another. However, multiple clinical abnormalities can cause either high or low cardiac outputs. High cardiac output is mostly caused by reduced total peripheral resistance. Following are some of the conditions that can decrease the peripheral resistance and at the same time increases the cardiac output to above the normal. This beriberi, arteriovenous fistula, hyperthyroidism, anemia. In the pictures we can see the venous fistula. And low cardiac output, there are two factors that causes low cardiac output. One is abnormalities that causes the venous return to fall to low, and abnormalities that causes pumping effectiveness of the heart to fall too. And so it is the end of the topic cardiac output and its discussion. Thank you all.